All right. Alex, is it showing okay?
Yes, yes.
All right. Then I'll go ahead and get started. Um, so this talk is one that I developed in conjunction with technical manager at Cedars-Sinai, Samantha, um, and it's on exposure index and reject rate analysis, which is the really exciting topic of radiation safety and image quality in digital radiography. And that's a great topic because that hits at least two or three different bingo words that people need for their continuing education. So we give this every few years to explain the quality control program that we have at Cedars-Sinai as a refresher to those technologists who have been there for a while, and as an introduction to the new techs about why we track certain pieces of information and what we do with it. So for this talk, I think the objectives will be to know the definition of the exposure index, to be able to use it for dose management, and to understand how the reject rate is used to assess performance. One of the things I like to ask people in a live session is, what is the purpose of quality control? Like, why do we do it? And I usually get answers that range from for patient safety to regulatory compliance, um, and so on. But and I agree with those, that the point of quality control is to protect the patient from unnecessary radiation, uh, to produce the best quality images for our radiologists, and to comply with state and national law. So I don't know if you are familiar with the Joint Commission, but there was a year where we had Joint Commission come inspect our uh, radiologist attendings. And the inspector asked um, our radiologist, "Can you tell me what is the exposure index?" And the radiologist said, "Don't bother me with this stuff. I don't know what that is." And so we make it a big point to talk about that on a regular basis now, so that we don't go through the same experience again where we have um, one of our staff or faculty telling an inspector we don't know about that and we don't care. So let's get uh, into the concept of the exposure index, or titled, you can just look it up yourself. So the exposure index is defined as the X-ray intensity at the digital detector, and it helps to determine the right amount of radiation for the optimal quality radiograph. Uh, it is never the dose to the patient, but throughout this talk, I'm going to be using the exposure index as sort of a proxy for the patient dose. And I don't want to say it's a tight connection; it's a little loose. But in patient populations, when you see the average exposure index go up or down, it gives you some clue about what the patient dose is experiencing. So the X-ray intensity determines the pixel brightness, and that's the one of the main components of image quality. And it's important to understand which pixels are being used for this EI calculation. So on the right, I have a plain chest radiograph, and there's two different directions that radiograph could go. It could be a chest exposure, and in that case, if we were wondering, is it correctly exposed, we'd look at the lung field, which I've outlined in blue as best as my shaky hands can do. And we could see that looks probably properly exposed. Uh, I'm not a professional in that area. I don't take radiographs of people. I take phantom pictures, and they're much more compliant and they never complain. Uh, but I would say that looks properly exposed. But if we were doing a T-spine, we, as I have circled in red, there's not a lot of information there. And there, the exposure index would indicate that it's probably underexposed. So the image segmentation matters. Are you trying to expose the lung field or the mediastinum or some other part? And whether it's under or overexposed depends on that particular anatomy. Well, so I mentioned that the issue of image quality, and that's why the detector exposure matters. So I don't know. There's got to be some people who are as old as me and have some memory of screen film. When I got to Cedars, we still had some affiliates that used screen film. Uh, so the image quality is tied to the technique and therefore the film dose. So a protocol that is too low dose is going to look bright. It's underexposed. And if the technique is too high, then it will be too dark. So that patient not only got more dose than they needed, but the film looks terrible. So just looking at the images, you can tell if the patient dose is right or wrong because the film looks good or bad. And this has to do with the H&D curve, that there's a portion of the film response to radiation dose that's linear. So if you increase the dose by 10%, the density goes up by 10%. Okay. But then there are extremes where you get very little response to more or less radiation. We call that the toe in the shoulder. And that means that you're not getting any proportional change in contrast with more or less dose. So that would be the area that you don't want to lie. And those H&D curves still have application today to digital imaging. And if you have ever fiddled around, which I guess is a big part of my job is just fiddling, is to look at the distribution of pixels, as we can see in my pictures A, B, and C. And the big change from film to digital radiography is that you can do digital manipulation of the image. So in this case, we're setting the window and level, looking at images A, B, and C. One of them is clearly too bright, and one is clearly too dark. And that would imply that the middle one is just right. And when I give this slide for my lectures, the big reveal is that they're the same image, which you could guess, but they're the same image, just processed differently. So I could take an underexposed film, underexposed digital image, and make it look good like B, or I could take an overexposed image and brighten it up, and again it would look like B. So can every exposure look good? And the answer is no. If you go too low in dose, it won't just be bright; it'll be grainy, and then everyone can see, oh, that's a bad image. Usually, radiologists let you know about that. On the other hand, if you overexpose it, you can almost always do enough windowing and leveling that it will get back into a good image. Which leads us to dose creep. And I used to have an image of the creeper here, and I think somebody explained to me that's 2 generations back. That's Scooby-Doo from the 1960s, and I finally had to give up on some of my old PowerPoint pictures. But dose creep is the gradual increase in radiation dose because of a decoupling of radiation dose and image quality. So when the field first started moving away from film to digital images, a research group tracked how many images were optimal, how many were overexposed, and how many were underexposed. And they found that over time, the proportion of overexposed images went up because there's no penalty for providing too much radiation dose. If people don't want to get a callback for producing a low image quality radiograph, they tended to overestimate the amount of dose needed. And so over time, doses were going up. And you could ask, well, what's so bad about that? And the answer is cancer risk. I usually tell patients that the riskiest part of their x-ray is making left-hand turns driving to the hospital. And it's at least in Los Angeles. I'm pretty sure that's true. But the thing is that we do a lot of these radiographs. And so we can't just talk about the risk to one person. We have to consider the population risk, where even though the probability of getting cancer from an x-ray is really low, if 200 million people all get an x-ray every year, then that's a lot of opportunities to maybe give someone cancer. So we always want to have the lowest dose that provides enough image quality to make a diagnosis. If I were getting an x-ray, I wouldn't want it to be so low dose that the doctor couldn't read it. So it has to be good enough for diagnosis, but no more. And so we need to have some kind of metric that will determine whether it's good enough or not good enough. And so we come to the exposure index as an experiment in trial and error. So fortunately, we don't try this method on patients necessarily, but I'll show you how we came to determine our dose levels and how to track those. So as I was mentioning before, we would like to have the lowest dose possible that will still give us adequate image quality. And the exposure index is the optimal dose metric for that. And the reason I say that is because the exposure index tracks the amount of radiation at the detector. And it's the detector that determines the image quality. And the opposing metric would be patient dose. Well, the thing is that patients come in different sizes. So a large patient is going to get a higher skin dose than a small patient, even if the same amount of signal arrives at the detector. So for a consistent program, we want to have a metric that's tied to the image quality and not to one that's dependent on patient size. So when I say that the image quality is dependent on the detector, it's set by the contrast, which is the difference in X-ray photons reaching each pixel of the detector. So as I showed at the very beginning, certain pixels feed into the calculation of the exposure index. So the EI is a measurement of the number of photons or dose that arrives at each detector element that are then incorporated into the calculation. So then we'd like to use this as a dose metric that will allow us to control our institutional radiation doses. So we're balancing dose with image quality. Now, there comes a point, which is, do we always need the same image quality? Does a wrist fracture study need a high quality image? And based on just the work that I do with our affiliates, I could say that our affiliated orthopedic sites want a higher target dose for the detector in order to see small fractures. On the other hand, at the main hospital, there are some studies that really don't need a lot of radiation or good image quality. So a GI study with say, a barium enema would be an example. You really can see it. You don't need to have a lot of radiation to make out the details. And because the abdomen has a number of organs that are highly radiosensitive, that's a really good place to cut down on our target dose to spare the patient the concern about cancer. So, how do we decide on this? At least at Cedars, we use a collaboration of physicists, technologists, and radiologists, and we're determining what is the image quality needed for the study, um, and therefore what is the minimum detector dose that's needed, and then how do we assign an EI to that and a manual technique and automatic exposure control technique that will achieve that exposure index. Then after we try it out, we get some feedback. Does it look good? Does it look bad? Is there a problem with it in practice? And that feedback loop then allows us to refine the controls that we employ. So there's a lot of different exposure indices out there, or at least there were. And I think we're converging on the exposure index as a definition as the dose in microrats. And to me, that's a really great number. Some places might have it as 100 times the dose in microgray, whatever. I don't care if it's standard or international units or whatever, but a nice linear relationship. For those of you who use Kodak or Carestream, they have their own system, and that's what our institution was using when I first got here. And it is a log measurement where the same amount of reduction, same number of points, is a reduction in patient dose by the same percentage. So it's kind of a decibel system. It's not nearly as intuitive, and trying to explain to people that, taking off 200 points from the exposure index starting at 2000 makes a big deal in patient dose. That could be difficult. I believe that this curve shows how our target dose has changed as we went from CR to DR to better DR technology. And finally, we actually have it down to EI 1200 for certain digital detector models. And I think that is an EI of about 150 in the IEC definition. Well, there it is. EI target is 150, or Carestream 1200. So do we ever deviate from that? And of course, yes, we do. For chest, my observation is that the technologists get their practice is to go about 25 to 50 points lower. So chest would be a lower target index. Lumbar spine absolutely needs a higher dose. And the reason for that is a lot of the radiation arriving at the detector is scattered. And the scatter doesn't contribute to good contrast. So they need higher doses in order to get more signal to begin with. So this is just showing how the different anatomies can benefit from a different dose index. As I said, our L spines use a higher dose. Pelvis does too. So we're probably looking at 350 to 450. I think that probably 350 is closer to the correct number, but people definitely need to jack it up sometimes. Portables are another example where we'll have a higher exposure index than the target, just because you have less control. And these two pictures demonstrate how much of a difference removing the scatter or adding the scatter back in makes. The left picture is without the grid, so that means that scatter is hitting the detector. And almost all of the mediastinal contrast is lost. All you can really see, I guess, is some of the lung field and maybe the boundary of the pericardium. Yeah, I'm no radiologist, but I can see that with the grid, uh, it's a much better image, even though the patient exposure was not increased. Uh, and that's different from how you would do a typical patient study. This was a research study. When you put the grid in, you have to compensate for it with a higher dose. But this is just a demonstration that even for the same patient exposure, you get so much improvement in quality with the scatter reduced. On the other hand, we've got two different knee phantoms. One was made at a Carestream EI of 1445, the other at a Carestream value of 1530. And we were asking the radiologist, can we lower the dose to the green level? And he said, I don't know. There's no pathology in there. They both look the same. And I guess that's true. So the question of whether you can keep lowering the dose really depends on how small or fine detail of pathology you want to see. For this knee phantom, it was a healthy knee, and he could see no appreciable difference between the two doses. So he went with the lower one. Um, so we have a quality assurance program at Cedars-Sinai to track these doses, the exposure index, and other associated patient dose metrics. And although the computer does a lot of the work, I still have to do a lot of it myself. So unfortunately, we haven't reached the point yet where computers can do a lot of the job for me. This is what our workflow looks like. And we have a quality assurance process improvement committee. It's called QAPI. I don't know who came up with that, but it's a QAPI committee. And it has certain tasks that the members take on a monthly basis. Some of it is collecting and measuring and analyzing the exposure and reject statistics. That's the big part that I'm involved with. Some of it is consistent machine performance. Here, the service engineer is important, as well as the technologist who does weekly QC to verify if the automatic exposure control is still working as expected. And then part of it is consistent ALARA patient doses. So that would be setting up our manual technique charts and setting our exposure controls so that the target dose is what we have designed to be our target. So how this works in practice, once a month, the physicist collects the data remotely from each X-ray computer system. So I'm managing 63 different X-ray systems at a lot of different sites, and fortunately, it's mostly managed through automatic software at this point. So I'm downloading the statistics from the station. It provides information on images that were made, images that were rejected, what the techniques were, what was the exposure index. So we're providing metrics to the QAPI committee on how often images are rejected, and by user and by protocol, what are the doses. Now, not every reject needs to be looked at. So there are categories that don't involve radiation to a patient. So these probably will depend on your service engineer who set it up. But we use these three categories: sensor error, basically QC testing, or what we call duplicate, where the software generates an additional image for us to manipulate, but it wasn't because an additional exposure was made. It's just done in the software. So those are not part of the reject analysis. I don't include the no reason because we just don't know what's going on there. But the rejects that do go into calculating the reject rate, the clipped anatomy, artifact, technique, motion, positioning error. So these count in the sense that a patient was exposed. Now, one of the things that I think is critical about this program is that this isn't about assigning blame to a technologist. And I think that's really important, and the management understands that. We're not looking to say that a technologist shouldn't have rejected this many images per month. All right, that's not really helpful, because then people argue about things like motion. Well, it's not my fault the patient moved. Of course, and we're not trying to assign blame or fault. But what we are looking at is that a patient received a double dose of radiation, and that counts as part of the reject rates. Now, there are limitations on using individual EI or reject, and the answer is that we are looking at a large pool of statistics instead of individual exposures. I can say, first of all, there are limitations where the software doesn't report a realistic exposure index. So when we go back and look at the technique that was used, it was appropriate for the body habitus. So why did we get some crazy EI? The answer is we don't know. And so if we were looking at an individual exposure or exam, we'd have so many per month. I run through about 50,000 exposures per month that have to be part of this analysis. And there's no way I'm going to look through all 50,000 and try to figure out whether the exposure index was realistic or not. But what we do find is that they follow statistical patterns. So there may be a distribution of exposure index for each room or for each user or for each protocol. If the peak of the distribution is on target, then that's a good sign. If, on the other hand, it's a very wide distribution or the peak is somewhere else other than our target, then it's an indication that there's something different going on with that user or that protocol. They're not adhering to our practice. Or there's a specific situation with them. One thing that I learned as the physicist that I'm sure you would understand as a technologist is difficult patients. As it was explained to me, there's a big difference between emergency room patients and outpatients. The ER people don't want to be there. At least at some of our locations, the ER patients are often intoxicated, and they're in a lot more pain, and they're not really interested in sitting still for you. And so I did learn a lot about why some users have higher reject rates or a higher exposure index because they just have to get the job done. On the other hand, the most common reason for having a high reject rate is being new. So what we observe is that the highest significant user is almost always someone who was hired in the past couple months or someone who was moved to a new location. They're not familiar with the equipment. And that suggests that we have opportunities for education where the user and the patient will benefit from more information, more experience, more knowledge about how to set the exposure levels. So these are the monitoring metrics that we use for our QAPI committee to provide feedback to the technologists to get more consistent performance. So this is what our reject rate looks like. Way back when we first started in 2011, we were finding that the average reject rate was about 15%. And for the highest user, it was 35%. So those numbers have been reduced dramatically we've been pretty consistently at 2.5% since then. And the biggest fluctuations come when new equipment is added. Uh, then we have some increase as the expectations are then implemented at a new site, or when we have new technologists, and maybe we'll get a wave of 4 or 5 at once, and then we do some education, and those rates come down. Splitting up our reject rate by reason can help pinpoint where technologists are having trouble and how we can help. You'll see that consistently positioning error is the number one reported reason for rejects. But for a while, we had a real spike in motion. And I have a suspicion that that was not correctly assigned. I'm not sure why patients would suddenly get more jumpy for a month or two. But that's something that we have the ability to work with any technologist who's only reporting motion. Maybe there's something they can do that would help the patient stay still so that their reject rates will look more like their cohorts. And then for Cedars, I have this comment about freehand data entry. Just as the physicist, it drives me nuts that there are so many different ways that people misspell words. For duplicate, I've seen DUIP, DUO, DUP, DUPE, and just a very wide range. So I just beg them, please, just you could all use DUP if you want, but don't make up unique spellings, because I just have no way to handle the data if each one is individual. Having seen the reject rates, let's look at the doses. So this is a selection of 4 high-impact protocols from our site. Initially, there was a much wider distribution of doses, and they were higher. So they've all trended down to be fairly stable at around 225. Although we are seeing a wider distribution of doses for L spines, and I think that we may have cut the doses too low. And we're seeing the technologists respond by increasing the dose somewhat in order to get better images. If you look at how tight the distribution of patient dose is, at the bottom right, the chest PA, that's a tight distribution. There's a relatively narrow range of patient doses being delivered. On the other hand, knees and shoulders, very broad. By technologist, we can see how their exposure index is distributed. I think this is over the course of a year. So user 1, 2, and 3 are fairly close together. And when we see a technologist who is significantly shifted compared to the distribution, that would be an opportunity to talk about, maybe what their expectations are for the correct dose. They might be used to different equipment where doses had to be higher. So our group has tasks now and for the future. Besides our current work of monitoring QC metrics, we have a research paper that's under review at the moment. We produce education materials for technologists here and for example, today. And we're looking at ways to continue to optimize our imaging so that we always get better images at lower doses, if you can. So here are a few projects in the time I have left that we were able to do some good work for. When we have an inspector come to our radiology department, they want to look at a few things, and one of those is the manual technique chart. So we know that AEC is appropriate to use for torso protocols. So it has a capacitor. It fills up with charge as the radiation arrives, and when it hits a preset level, it cuts off the exposure. That's basically what's happening. And there are ways that that we can work together to set the point at which it cuts off, so that our target dose is hit at different energy levels. So, say 50 kVp, 80 kVp, 120 kVp, um, and for different body sizes. But it only controls the mass. So you choose the kV, and then we're setting the exposure cutoff to be uh, at the right mass. But for extremities, or if the AEC were to go down, then you would need a manual technique chart. And our inspector reviews those with us, make sure that we have all of the attributes on there that are required. So in the past inspections, um, we've had to add categories for small, medium, and large. We have to have the skin exposure for each technique, whether or not a grid is used for each protocol, and what is the target exposure level for each of those. So this is what our technique chart looks like. I can only show a few lines of it because otherwise it'd be too small to read, but it's got the technical factors there. It's got the ESE, which is the entrance skin exposure. We've got the table or wall grids and the grid ratio. That was another thing the inspector wanted to see. And then I sign and date it so that we've got proof that we're keeping up with these. Recently, or somewhat recently in my career, we were hit by an inspector about collimation. So the requirement was that the blades are visible in the image. So if you look at this image, there's the shoulder, the humerus, the body anatomy. There's the black triangles, and that's the masking. But the collimator blades themselves are the white borders, where the lead was in the field of view and stopped the X-rays. So the collimation has to be at least 1 inch away from the anatomy of interest, but at the same time, the inspector requires it to be visible in the image, and they know how to take the mask off to verify that it's there or not. So then if we were at Cedars, we would take a quiz. But I think let's just go through a few questions. I usually like to do this during the talk. I wasn't sure what the format here would be like. But Alex, would you be willing to volunteer some people to answer some questions for me?
Yeah, sure thing. Let's see. We have David Mendoza.
All right, David, you there?
Um, so for I would say the amount of remnant radiation hitting the exposure, sorry, the detector
Yes,
would,
I agree with you completely. The
okay.
exposure index is determined by the detector dose. So thank you. You're the first person who volunteered. If you were in person, I'd toss you a Snickers bar. Alex, can you get me another one for a true or false?
Sure, let's see. How about Dallas Fair?
All right, so we've got a true or false. Without EI tracking, doses in digital radiography tend to rise over time.
That is true.
That is true. All right. I think this crowd knows this material. All right, Alex, who's next?
Let's see. Angela Arcia. Sorry if I mispronounced that.
So, Angela, this is a bit difficult because I think all of these are actually used. Well, maybe not one of them. But what's the standard for calculating exposure index?
Hi, I'm sorry, I had it on mute. I would say the orange one, EI equals 100 times a dose, micrograys.
Excellent. Okay.
Nice.
All right. Who's going to tackle this one?
Let's go with Sabrina Khan.
I would say it's true.
Okay, I agree. Sabrina, do you do digital radiography imaging?
Yes.
Do you know what your target EI is?
I'm not sure.
Okay.
Sorry.
Okay. Well, thank you. I appreciate it. You could have just said, "Oh yeah, it's 175," but it's a good question, and it varies from site to site. Um, we're almost done. I think there's one question after this. So, Alex, who's going to take this one?
Let's go with Edwin Lin. He typed in the chat false.
Okay, false. AEC should be used for every exposure. The answer is no. Um, interestingly, when I first started at Cedars, there were at least some technologists who believed that if you were experienced, you shouldn't use AEC at all. You should only do manual, and that was an interesting thought because I can see the point very much. But what that those individuals didn't realize is that the technology was advancing. So they knew the right manual technique for the old technology, but as we were, paying a few $100,000 for something new, um, it was able to use less radiation for the same quality. So using the AEC was helpful to the patient. I think this is the last one. Alex, can you get us a volunteer
Let's go with
or a
Miranda
voluntold?
Strong.
This would be true.
I agree completely. And we have joint commission coming for us, so we'd better make sure that we have a manual technique chart on every piece of equipment. Alex, you've got a good group of people. When I teach radiologists, they don't answer questions like this. So I appreciate it. That really makes me feel like even if even if you didn't learn anything tonight, it means that you already knew it all. So that's a good sign. Do you want me to stay on for any questions?
Uh, do we have any questions? Feel free to type them in the chat or say them out loud. Just give it a minute, just in
Hi,
case.
this is Rich.
Hey, Rich.
I have a question. The vast majority of the audience here are students and/or new technologists. You were talking about repeat rate. What is a reasonable expectation for a new technologist for a repeat rate? I mean, obviously, we all repeat exposures. I mean, it just happens. But
Yes.
what is considered over the line, which would maybe require sitting down with the supervisor and having a chat about what's going on?
That's a great question. So I'm just going to answer for Cedars because it's not my business how other places run. But for us, our action level is at 7%. So if you're above 7%, again, it's not like an HR counseling. We're just there to say, can we help you make fewer rejects? We might see people who are coming in and they do like 13% rejects. There's a good opportunity to reduce that. And then once people are down to 5, I think 5% is probably a good place.
Thank you.
Yes, sir.
Just a follow-up question to that one, actually. I was wondering because I think somewhere along the presentation you say you guys ask, how do we help you and provide education to them? Would it be like this presentation that you did, or how is it that at Cedars it's handled?
Also a good question. So I said that I developed this in tangent with Samantha, our technical manager.
Right.
So she, as I understand it, she would go to that person or maybe an experienced technologist and just see like, is there something that technologists could improve on? Are they having trouble getting the patient to stay still? Are they familiar with how to position the field? Probably the exposure index is a little bit easier to control. I've noticed even the really experienced technologists, if you bring them into a different site on Christmas Day, their reject rate is not going to look good. And yes, that did happen. So you just have to understand that when people are in a different or difficult situation, the rejects go up. Making it more familiar helps it go down.
Right.
Is that your experience as well?
It does seem like every time I get put in a room that I'm not entirely comfortable with, yeah, I will tend to repeat more. There's some equipment I'm still getting used to. The Philips machine likes to sneak up on me, and I forget to reset the Bucky slot. So,
Oh my gosh.
right.
You and I, we're talking the same language here.
Yeah, thank you for answering that. Do we have any other more questions? I don't see any in the chat. Feel free if you guys need to type it or if you want to unmute to say it.
And I did send the slides to Samantha, so if you want to distribute that, go for it.
Yeah, I will send it out to everyone who is registered.
Alrighty.
Everyone who's on this meeting today will receive it.
Well, in that case, thank you very much for inviting me to
Of
talk
course.
to you. It was really nice to do something new.
Of course. Thanks for agreeing to present for us. It was a great presentation.
Thank you so much.
Of course.